Okay, well, good afternoon, everybody, and thank you, Mr. Alt. That was really fantastic. So we're going to move from New York City and take a look at the global picture briefly in terms of awareness of HIV diagnosis. And a lot of what we know, particularly about awareness of HIV diagnosis in sub-Saharan Africa, comes from the Thea project, which I'm going to talk to you about, and drill down even in more detail in terms of what we now know about awareness of HIV diagnosis in Malawi. We'll be looking at some data on gaps in awareness, and very briefly I'll give you a picture about some innovations in testing, and then try to lay the groundwork for our panel discussion and thinking about some of the discussion points on the way forward. So just in terms of the global picture, WAFA showed us some data from the UN AIDS report that just came out in 2018, and this slide comes from that as well. And it shows us really very clearly how much progress globally the global community has been making with that first 90 of knowledge of HIV, because in 2015, 67% of people living with HIV were aware of their diagnosis. That increased to 70% a year later, and then up to 75% in 2017. So that means that the target of reaching 90% by 2020 is looking like it is actually well within reach. So I think that theme that WAFA mentioned at the outset of, we're achieving progress, but there are still gaps, really is illustrated very nicely with this slide. Now, the information about the first 90, you have to sort of step back and think, well, how do we know that? How do we get this data? Initially, this kind of data came from facility-based data, people who already had their HIV diagnosis and would come in and seek care. But recently there has been more and more data available that goes beyond population-based data that goes beyond facility-based data and tells us what's going on in the population at large. And one example of that is the Population-based HIV Impact Assessment Project, or the PHIA project. And the PHIA project is a series of nationally representative HIV-focused household surveys that are designed to assess the HIV epidemic and the impact of response programs in 14 countries that you can see there in the map on your left. The colors just give you a snapshot of where the surveys are right now, with the dark gray color show you where the surveys have been completed. The two countries in green, Rwanda and Kenya, the surveys are happening right now. And then the 14th country, Haiti, in yellow all the way on the left corner, we're in the planning stages. And for nearly all of these surveys, the primary objectives are very similar: to assess national HIV incidence and the prevalence of viral load suppression. Each country then has a very long and lengthy list of secondary objectives, but they overlap quite a bit, and they include an assessment of HIV prevalence, the 90-90-90 cascades, which we've already had an introduction to, levels of detectable antiretroviral agents in blood samples from individuals living with HIV, and many other secondary objectives. So I'm going to take advantage of what we have been learning from the PHIA project and talk more about awareness of HIV, or that first 90. Before we go into that, I wanted to just give you an overview on the PHIA project methods so that it makes it a little bit easier to understand the data. These are all cross-sectional, two-stage cluster samples, which are designed to result in nationally representative data. They're powered for national HIV incidence and subnational viral load suppression. They typically are sampling about 30,000 participants, including somewhere between 5,000 and 10,000 children. Household members who slept in the selected household the night before and provide informed consent are eligible to take part in the survey. We use household, adult, and adolescent questionnaires to collect demographic, behavioral, and clinical information. We use electronic data capture, and typically it takes about 6 months to complete the field work. Laboratory methods are conducted at a few different levels. In the household, we're doing a venous blood draw. We conduct HIV rapid testing according to the national algorithm of that particular country. We return the results and provide counseling and referral for care as needed. The blood samples are then taken to a nearby satellite lab, typically a district hospital lab, and we conduct QA and HIV confirmatory testing. And then the samples are transported again to a central lab or for certain tests, labs outside of the country for viral load, incidence testing, early infant diagnosis testing, and ARV detection. And then the data are weighted for survey design, non-response, and population projections to achieve nationally representative data. So we could, of course, spend a whole talk just on these methods, but I wanted to just give you the big picture view to put it all into perspective. The reports are available on the project website, thea.icap.columbia.edu, where you'll find summary sheets. For a few countries, we have brief first reports, and we are now putting up final reports and slide decks, and I've listed for you the kind of data that you can find in the final reports. We have our very first final report is now up and on the website, and that is from the Malawi project, and that is why I'll be showing you more detailed data from the Malawi Thea, because those are publicly available data. So let's take a look at what we've been learning from the Thea surveys about the 90-90-90 results. And what you can see here on this slide is the range of the results. So if you look all the way on your left, you see in Côte d'Ivoire, starting with the dark green bar, 37% of individuals who tested positive in the Côte d'Ivoire Thea survey told survey staff that they were aware of their HIV diagnosis. Of those who said they were aware, 88% reported being on treatment, and of those who said they were on treatment, 76% had a suppressed viral load under 1,000, as measured in the survey. Now, Namibia, in the middle part of the slide, is at the upper end of the 90-90 achievements, where 86% were aware of their diagnosis. Of those, 96% reported being on treatment, and 91% had a suppressed viral load as measured in the survey. And that is a very impressive achievement for Namibia. And I've put the United States data that we found from CDC, analyzed in 2015, all the way on the right, just to provide a bit of context. So in the US, it's estimated that 86% of people living with HIV are aware of their diagnosis. In turn, 74% are on treatment, and then 81% of those have achieved viral suppression. If you look at the height of the gray bars, it gives you the whole range of where each of these 3 locations are towards achieving overall viral load suppression. So in Côte d'Ivoire, about 25% of the HIV positive population has achieved viral load suppression. In Namibia, it's just over 75%. And in the United States, from this data, it's 50%. So we really get sort of a nice picture of the range of 90-90-90 achievements. So let's drill down a little bit deeper in Malawi, and as I mentioned, I'm picking Malawi because we now have the final report that's available from Malawi. So here we can look at awareness by age and gender, and just for context, I want to remind you, if you didn't already know, that Malawi is considered a high prevalence country where national HIV prevalence is just over 10%. So starting on your right, looking at the total numbers, the 2 darker colors correspond to individuals either between the ages of 15 to 49 or 15 to 64. And there we see that almost 3/4 of individuals of adults in Malawi were aware of their diagnosis, so that's impressive progress. For the younger ones, the adolescents and the young adults, it was only 50%. If you move to your left, you can see the breakdown. And in every case, for each of these three age groups, men were less aware of their HIV diagnosis compared to women. And in particular, I think the 37% for young boys and adolescent boys and young men is quite an important gap to think about. So let's try to learn a little bit more about what this awareness gap might be about. And here's some additional data from the Malawi PHIA, where we asked not just people living with HIV, but everybody in the survey about their HIV testing history. So for individuals, adults either 15 to 49 or 15 to 64, most, 74%, said they had ever tested. Now, as I recall from Bisrat's talk, that is actually a little bit higher than what we saw in New York City, where 65% reported ever testing. So here, Malawi, a country with significant challenges in terms of poverty and literacy, is really doing very well for ever testing. It's a little bit lower for the 15 to 24-year-old. Then in looking at data for the last 12 months, 36% reported testing in the last 12 months. And I think that's perhaps a discussion point for the panel. Is that good or is that bad? I think it sort of depends on what you want to compare it to, and you need to think about HIV prevalence context. And again, for Malawi, it's a country where HIV prevalence is 10%, so one might say maybe a higher proportion of individuals really should be getting tested every 12 months. Now, how about information about self-testing? How do people in Malawi feel about HIV self-testing? Well, here, what we can see is that people are interested in it, at least hypothetically. They're saying that they would use an HIV self-test kit if available. So for the 15 to 64-year-old age group, actually slightly more men than women, 77% said that they would use a self-test kit if available. And looking at the younger age group, it really doesn't drop down very much at all. Younger individuals are interested in this. And remember, I showed you that 37% of young men in Malawi were aware of their diagnosis. So this kind of data suggests that a self-test approach could be very helpful for young men in Malawi. Let's take a look at knowledge about HIV transmission and prevention. Now, we assess this based on a series of questions about HIV transmission and prevention that are fairly standard and are used in a number of these kinds of surveys, not just PHIA, but also demographic and health surveys. And we see, I would say, really substantial gaps here in knowledge among adolescents and younger adults. So among those 20 to 24, about half correctly answered the questions about HIV knowledge and transmission. For those 15 to 19, only about 40% correctly answered the questions. So this suggests one of the areas of, one of the reasons we see the gap in knowledge about HIV may have to do with knowledge about transmission and prevention. Rounding out the data a little bit more, here's some information about discriminatory attitudes towards people living with HIV. So in the survey, everybody who was participating in the survey were asked two questions that I have there at the bottom of the slide. Would you buy fresh vegetables from a shopkeeper or vendor if you knew that this person had HIV? And about 7% answered that question with a no. And then the second question was, do you think that children living with HIV should be able to attend school with children who are HIV negative? And about 7% answered the question with a no. And about 11% answered no to both questions. So that gives us one type of picture on discriminatory attitudes, among people living with HIV in Malawi. And then thinking more about disclosure, here's an additional piece of data that we have from the survey. the bar all the way on the left, the self-reported, is the awareness, as we've already been describing it. But we've been able to take that information about awareness one step further because, as I mentioned in the methods, we've been measuring blood samples from HIV-positive individuals for detectable levels of antiretroviral agents. So what we did here was we said, let's define awareness as not just self-reported knowledge of their HIV-positive status, but self-reported knowledge and or detectable ARVs in their blood samples. So here's what happened when we looked at that and or approach. It moved up from about 73% to 77%. So about a 4% absolute increase or 5% increase from the self-report. So you might look at that and say, well, this is evidence of some important stigma and discrimination because people did not want to disclose their status to the survey staff in the setting of an HIV household-based survey. Or you could flip it and say, actually, it's a very encouraging picture because the vast majority of people, in fact, were willing to disclose their status. And here I have some unpublished data for you from 8 countries that shows not just what the picture is like in Malawi, which is in the middle, but from several other countries, and it's in sequence of how big that gap is at the top. That's the difference between self-reported first 90 and self-reported combined with detectable ARVs. And certainly it is a larger gap for Namibia and Tanzania, but I think if you take the glass is half full approach, or even you might say the glass is 90% full, you'd say this all looks rather encouraging. But again, this is specifically for the setting of what people are willing to disclose to survey staff in the setting of a household-based survey. The UNAIDS report has some more sobering data about stigma and HIV testing among people living with HIV. Here, this graph shows the percentage of people living with HIV who reported hesitating to get tested for HIV because of fears of how other people would respond if they tested positive. So this is from among all people, not just people living with HIV. And you can see it ranges from about 20% in Cameroon to about 40% in Uganda. So that's certainly something to be concerned about. And I think we saw this slide very briefly before with Watha's slides. This moves in not just from everybody, it's not just all persons, but among key populations. So gay men and men who report having sex with men, sex workers, and people who inject drugs, each in either the dark black, the red, or the light gray color, who report having avoided testing in the past 12 months due to stigma and discrimination in countries with available data in the past 4 years. So we see quite a big range from about 40% in Laos and then 30% in Fiji to much lower levels in Zimbabwe. So this just gives us a little more complete picture of what might be going on with stigma and discrimination among key populations. So now I'm going to step away from all of the PHIA data and the UNAIDS data and just for 2 slides tell you about some of the testing approaches that we've been using and in particular give you some example from Tanzania. Over on the left, that vertical HIV testing diagram gives you an idea of sort of an older approach to HIV testing, which was what we call very vertical. So there would be provider-initiated testing and counseling, or voluntary counseling and testing, index testing, mobile testing, contact tracing, and outreach, each kind of in their own little worlds and not really communicating with each other. The more integrated approach is there on your right and gives you an idea of what it would look like to integrate provider-initiated testing and counseling with client-initiated testing and counseling at HIV care facilities. In the middle, index testing and contact tracing. And then thirdly, targeted outreach for those who are not coming to facilities, and all of it combined with self-testing across all of these steps. And just because I figured some people in the room might not quite have a understanding of index testing. That is the testing of sexual partners or family members of HIV-positive individuals in a community-based setting. So here from ICAP Tanzania's PHIA project, we see that there's really been combination testing that's been going on. We've heard of combination treatment and combination prevention, and here is combination testing where people are screened before they're tested so that those who really need it can be targeted. There's same-day index testing, and I put that in quotes to say, well, if not exactly same day, then as close as possible to the same day. Delivering testing through healthcare workers carrying backpacks. They go on foot to the client's preferred location, and then engaging peers to reach their social networks. And by using this approach in our Tanzania program, we've been able to improve the targeted increase in identification of HIV cases from about 4,000 in 2017 to over 14,000 in 2018. So a tripling just in 1 year. So going back to this slide about our first 90 and where we are with 75% versus 90%, couple of questions. How many people need to be tested to reach that 90%? And how many tests are actually being conducted globally? Well, 75% of the 37 million who are living with HIV is 27.7 million. The target of 90% is 33 million. So it means about 5.5 million people need to be tested to reach the 90%. That seems like something that really should be within reach, especially when you think about the number of tests that were supported in 2017 by PEPFAR and the Global Fund. 174 million tests. That's just a minimum. I'm sure there was a larger number than that. So how can we figure out how to use those 174 million tests to find the 5.5 million who need to be made aware of their diagnosis? Which set of testing strategies is the way forward? More efficient testing strategies, or those strategies that really work to normalize the act of testing? So to close, the new population level data from the PHIA surveys provide an important opportunity to assess the effectiveness of HIV programs and tailor future efforts. The results are encouraging, but they underscore the need to engage men and young women to fully achieve the targets, especially the first 90 for all populations. And we can think about and talk about HIV testing strategies. How should we balance the need for more efficient testing strategies while minimizing stigma and discrimination? I want to thank the many, many people involved in the PHIA project. Many of you are in this room and work tirelessly to keep the project going, in-country and international partner organizations, and our funding from PEPFAR. Thanks very much.